Thank you. All right, so actually, I think this will be a nice follow-up to the previous presentation. We're going to dive into another perhaps underappreciated condition of advanced HIV and ways to move forward with that. So I'm going to talk about definitions and epidemiology, approaching AHE to reduce morbidity and mortality, adapting differentiated service delivery principles, which we use in management of HIV in general for the AHD packages of interventions. And I want to touch a bit on immune reconstitution inflammatory syndrome because it seems to come up a lot as we talk about AHD. So what is AHD? And so just these are the common definitions at this time, including adults and adolescents and children above 5. It's defined based on objective criteria. The most accurate is probably CD4 count of less than 200, but we still do accept WHO stage 3 or 4 events or status as a definition of advanced HIV disease, recognizing, of course, that that is a more difficult criteria to ascertain. Also just emphasizing, and there was a lot of back and forth over the years, but we've landed on the notion that all children younger than 5 years old are considered as having advanced HIV disease, and that helps a lot in terms of our approach to that particular age group. So just talking a bit about using the objective criteria that I mentioned, which is CD4 testing, you can see that actually a baseline, and we heard a little bit about it in the earlier presentation, but you can see that baseline CD4 testing does vary across, CD4 counts do vary across regions, but also important to recognize that access to CD4 testing at ART initiation also varies across regions, and that is not necessarily reflected here. I mean, it can be reflected here in terms of what you see where in this particular region, Asia-Pacific, CD4 testing is more available than, let's say, in Southern Africa. But we've also noticed this trend, which was mentioned earlier, that people in this region are presenting with a higher prevalence of CD4 less than 200, or in other words, a higher prevalence of AHD. And I think that's something we want to be paying attention to moving forward. And I have some thoughts on that, and be happy to get into a discussion over the course of the conference. Also, the other thing, we do focus a lot on people who are starting ART for the very first time, but with the advent of a number of surveys that we do in the PEPFAR realm through CDC, we have some information also on people with treatment interruptions. And what we're finding is that people with treatment interruptions, they also do present with low CD4. So perhaps their CD4 began to drop, as we'll talk about, and also with viral load on suppression and a low CD4 makes it even a higher risk factor. So we're not just talking about people initiating ART, we are also talking about people who have experienced interruptions, and obviously that's another motivation for why we want to do everything we can to prevent interruptions in therapy. Philippines was mentioned earlier, and there is there has been a note about the increase in incident cases, new diagnoses in Philippines, especially for this region, even in the context of this region. And I think also we're seeing a lot of advanced HIV disease at the time of presentation. This slide was by the Ministry of Health in Philippines, a few slides here. And I think the other thing we should be noting is that 15 to 19-year-olds and 20 to 24-year-olds. So typically we think that you need to be infected for a certain number of years in order to have advanced HIV disease. And if you think about age as a proxy for how long you were sexually active, and therefore how long you were at risk for HIV, and therefore how long you're likely to have had HIV, to have 19% and 22% in those younger age groups already with advanced disease suggests either one of two things. I mean, it suggests that age of infection in this group is alarmingly young, or the second possibility is that there may be something about the circulating HIV variants in the Asia-Pacific region that might cause a more rapid deterioration of CD4, more rapid, shorter time to immune suppression. We've discussed this. We don't really have any specific. There's some hints in some of the laboratory bench data that we've seen, but nothing that I can actually say is known at this time. These are only theories. And again, of course, not surprisingly, you'll see, if you see an increase in advanced HIV disease, if you see an increase in number of people living with HIV, as we're seeing in Philippines, you're also going to see a number of AIDS-related deaths increasing, and that's what's being shown in Philippines. And then this is data that PEPFAR here in Thailand has put out with the number of provinces of regions that PEPFAR supports, and you can see that baseline CD4 less than 200 is quite high even in this country. Now, the interesting thing about this country compared to, let's say, Philippines is that we're talking about a country with a higher first 90, a higher knowledge of HIV status, a higher second 90, a higher percentage of people on HIV and on treatment with HIV on treatment. And so what we might be seeing is that the group that we're still having trouble finding, let's say in a country like Thailand, the group with HIV that we're still having trouble finding also may be the group that has been infected for a longer period of time, and then by definition more likely to have a lower CD4 or a higher prevalence of AHD. So there's a lot of epidemiologic phenomenon happening here that might explain this phenomenon here in this country. Okay, so let's talk about approaches that, especially in the PEPFAR world, that we're trying to take to address AHD to reduce morbidity and mortality, because that obviously is our main goal. And so what we've done is we've sort of organized our thinking about how we want to manage AHD into 4 pillars: prevention, diagnosis, treatment or management, and then impact. And so, and of course, sort of at the base that you see there is commodities, forecasting, and stock management, because all of these, important to understand that all of these interventions do require commodities and that are available. So whether it's in the case of some African countries, we have very low CD4 test availability, and so therefore we don't even have the commodities available to us to get to the diagnose pillar, much less treat management and have impact. So I think it's important that we don't forget about the need for the commodities and forecasting in order to implement these 4 pillars. And so, just in terms of prevention, so we think in our world of prevention of treatment interruptions as obviously an important goal, and we think of it from the standpoint of maintaining viral suppression, because that maintaining viral suppression also can reduce transmission. It also can reduce immune suppression or advancement to immune suppression. So it's really become very important that we think about treatment interruption as a preventive mode for advanced HIV disease. And maybe we don't always think about that because we're very focused on viral suppression, but it's a very important thing to think about. And this is just some data showing the effect of treatment interruptions, how quickly you can develop immune suppression over time or a reduction in your CD4 count with the treatment interruption. Also, as I mentioned earlier, while we do have the option of using WHO stage 3 and 4 to diagnose advanced HIV disease, and of course children under 5 are by definition have advanced HIV disease, for the most part we need CD4 counting in order to be able to diagnose AHD. And not only does, so of course, I think that probably makes sense to most people, but I think what we see in this study here is that we actually will see a decrease in these negative outcomes. So this is total TB deaths, TB mortality, cryptococcal meningitis death and mortality. And what we see is that when we are, so first of all, the biggest increase is if we don't do an intervention for these diseases, obviously we don't have much of an impact on death and mortality. But if we do the intervention, we do. But if we are blind to whether they have advanced HIV disease, then the impact of that intervention is relatively limited, because somewhere between in the case of TB, here and here are people that are not known to have AHD, and so therefore we don't know how to be aggressive with diagnosis and management of TB or cryptococcal meningitis. So it's very important that we have CD4 testing available, and we feel like we need to revisit. I would say that PEPFAR, in retrospect, probably made an error in terms of de-emphasizing CD4 over emphasizing viral load over CD4, when probably in retrospect we should have just been advancing viral load, but not at the expense of advancing viral CD4 testing. And so now we're having to catch up on some of those mistakes that I think we made. And then you see here, so right now, here's the landscape we're dealing with right now, because we have quite a differentiation between CD4 reporting completeness. So these are all countries with huge HIV epidemics that do not have any CD4 counting available, at least not reported in those cases. And so all of that, thinking about that previous slide, all of that becomes missing information when it comes to being able to improve morbidity and mortality. Okay, and then breaking it down to just a few countries, here's where we see AHD at treatment interruptions, and again, we will see it in various countries. I think, as I mentioned earlier, in a country like, let's say, Rwanda, which is very close to 95, 95, 95, you're still going to, who are the people that you still have not diagnosed? Who are the people that you still have not started on treatment? They may be people who are much harder to find, hiding somewhere from you because of society norms or whatever the various reasons might be, and therefore the likelihood of progression of their HIV to AHD becomes increased. So I would say that we may never get below 20% for AHD at initiation. The hope would be that the number of people newly diagnosed with HIV continues to go down for most countries, but we may continue to see 20% be the number who have AHD at presentation. So we have to keep our activities moving in this direction. Okay, so I mentioned CD4 testing. The CD4 testing landscape is really too complicated for me to understand, much less to present to you. But except to say that, as I mentioned earlier, CD4 testing has, in the diagnostic community that supports the work that we do, CD4 testing has been de-emphasized. Okay, and so therefore we need to push for a reversal of that trend. And so what we're seeing is some major suppliers of our CD4 information have actually stopped supporting the platforms. And so right now this is all heading in the wrong direction. Now what we're hoping is that we have some newer technologies. This is just an example of some technologies that some colleagues of mine provided for me, but just some newer technologies that might be available that could help us reverse that trend, because we need to have CD4 testing available. And I think rapid CD4 testing, as long as it's sensitive and specific, I think rapid CD4 testing would be ideal, because obviously when we're going to talk about the interventions that need intervention packages, the sooner you can initiate the sooner you can diagnose a person with advanced disease, the sooner you can initiate the intervention package, the sooner you can have the greatest impact on their outcome. And one of the things that we're doing in PEPFAR is we want to do just a landscape of what we call a CD4 network assessment. So we're looking at these realities of these platforms that are being phased out by the companies and not necessarily being replaced, and what are we going to need to be looking at in the future in terms of CD4 networking, in terms of CD4 capacity, in order to do all the things that I'm asking that we do, which is, you know, to be able to screen and diagnose AHD in all newly infected, newly diagnosed HIV, and also people returning to care. So I think that you know, this is a network assessment, and then from there we hopefully will have a logical plan for the steps that we need to take to improve CD4 testing access, similar to what we did with viral load, and were very successful a few years ago. So PEPFAR, and this is aligned pretty much with global guidance, but PEPFAR is recommending CD4 testing among 3 groups at treatment initiation for all PLHIV above 5. That's anyone. So, and as I mentioned, everyone under 5 is already considered to have AHD. Upon reinitiation of treatment, with interruptions of at least 6 months, recognizing that it does take some time after treatment interruption to have a reduction in your CD4 count, and so we don't necessarily need to do a CD4 in everyone reinitiating. And then for individuals with documented virologic failure, again, recognizing that persistent virologic failure or non-suppression of the virus eventually will lead to progression of disease and immune suppression, and so we want to test for CD4. So when we do the network assessment, these are what we're modeling for in terms of the volume of CD4 testing that needs to be done. And I'm not going to get into a lot of details about AHD in children, but I do want to not forget about the situation with children, and so we can see here that mortality, that the group under 1 has the highest mortality of any of our groups that we are dealing with, living with HIV. And you heard in the previous talk about the also aging mortality, so just point that out on this curve. But so it's very important that we recognize that diagnosing HIV in a child under 5 is only the beginning. It's not everything you need to save that child's life. So there might be other interventions, and you should be looking at some of the predictors of mortality, and then design your interventions for children in order to prevent those mortalities. And so these are all steps that we are taking at CDC and through PEPFAR to try to promote prevention of mortality among children living with HIV less than 5, who, as I said, by definition, all have AHD. Okay, so we have a package. WHO has a package of interventions proven to reduce deaths that include rapid initiation of ART, cotrimoxazole prophylaxis, screening for active TB disease, screening for cryptococcal disease, and intensified support to ensure adherence to the AHD package. Okay, so this is 2017. We've known what and the data that informed this came out even well before 2017. So we know what we need to do to respond to AHD and prevent or mitigate morbidity and mortality among people with AHD. And so we do see uptake of AHD guidelines, so a lot of green there. So yes, AHD guidelines have been fully adopted in policy in these countries, but in my mind, that is a somewhat superficial view of this situation, because I think, as most of you know, it's one thing to have something in policy, it's another thing to turn that policy into practice. And this is a slide that was shared recently at the Sequin annual meeting in Johannesburg, in which they basically show that kind of exactly what I just said, which is that you can have a lot of policy implementation. So on paper, you have a lot of things happening with high scores for policy guidelines, coordination, but then when it gets to actually client coverage, testing for AHD, facility coverage, some of the actual implementation indicators, you see much poorer performance. And so we need to be turning these policies into actual practice at the clinic level. We need to identify what are the barriers to practices at the clinic level. Every clinic has unique barriers, and I think in maybe a CQI type mode, important if you're having trouble if you're having trouble testing for AHD, if you're having trouble implementing the AHD package, to do some sort of CQI project at your clinic to see what are the barriers and how can those barriers be resolved. And then of course, we're all familiar with the differentiated service delivery package that we give to people related to ART delivery. I think we have to, we need to have a similar approach to AHD packages. We want to identify the AHD, clinical package to screen, prevent, and treat. All of these things need to be happening at the clinic site. And what we also need to be thinking about is that in terms of what is the approach to a person with AHD that's going to improve their morbidity and mortality. I think there's a paradigm that the people who have AHD need the most intensive monitoring. But how well are people with AHD going to adhere to intensive monitoring? So for example, if you feel like you need to see a person with AHD every month, then is that person going to come every month, or is that person going to drop out of care? You have to be worried about that. So what are things that we can do where we modify our expectations and our comfort levels in order to ensure that the patient remains in care? Is it televisits? Is it phone calls? Is it case management? What are the things that we can do to meet the person at the needs that they have, recognizing that they have AHD and they have special needs from a medical standpoint? They also probably have special needs from a socioeconomic standpoint, but they have special needs from a medical standpoint, and we have to find a way to meet those needs. And so these are some of the using the differentiated service delivery model that has been developed by IAS. These are approaches that can be taken. I won't go into a lot of details about them, but you can imagine that this is just with this one particular scenario, just understanding the when, the where, the who, and the what. So you can't, just following that sort of model that I think IAS has done a good job of promoting over the years, starting with management of people with HIV. And then this is a common situation too, is that you have a person, obviously a person with advanced HIV disease is more likely to end up in the hospital, either as their AIDS diagnosis event, so to speak, or because they just get sick and end up in the hospital. And so very obviously, though that particular scenario is the most important scenario that needs proper engagement in follow-up with OPD, and so making sure you have some sort of plan in place for when a person is discharged from the inpatient hospital, how are they going to get to outpatient in a timely fashion so there's no gaps in their treatment, there's no gaps in their management of their advanced HIV disease, and of course follow up on management of whatever, if it was an OI, whatever the OI was for the hospital that led to the hospitalization. Finally, I want to talk a little bit about immune reconstitution inflammatory syndrome, or a lot of people call it IRIS. This comes up a lot, and I think that it's especially a concern in settings, I mentioned Philippines, even here, where you have a high proportion of people initiating ART who also have who have low CD4 counts, who have advanced disease, and therefore are at risk for having OIs at the time of what might be the time for antiretroviral initiation. So what is IRIS? It's an inflammatory disease that's due to reconstitution of pathogen-specific immunity with effective viral suppression. So associated with increased production of inflammatory cytokines by the CD4 cells. So basically, when you have a person come in with a high viral load and a low CD4, and you initiate antiretroviral therapy, the virus can become controlled fairly rapidly, especially with our new dolutegravir-based regimens. We can see viral control within 2 to 4 weeks. And so as a result, you have this, and then eventually you have a buildup of the immune system, but that buildup of immune system can be associated with inflammatory cytokines and other symptoms that we commonly think of as IRIS. It can be paradoxical, which basically means a person is diagnosed, let's say, with TB, and then the TB seems to be getting worse as the immune system is being reconstituted. because of these inflammatory cytokines and other inflammatory markers that the existence of, let's say, TB is leading to. And so the risk factors obviously would include a low treatment CD4 count, and you see a list of pathogens. There are probably some other pathogens unique to Thailand in here, and we may hear about them more in the case studies that are going to happen later on in this conference. But I think so that's basically what IRIS is. Now, what a consideration, we want to prevent IRIS, okay, but what we also have to remember is there's a risk benefit. So there's the risk of IRIS and there's a benefit of preventing IRIS, but there's also the risk of HIV itself and the benefit of antiretroviral therapy. And I think it's very important that we weigh those two risks and that we don't say that the worst thing that can happen to a patient is they get IRIS, because I've seen IRIS. It's not the worst thing that can happen to a patient. It's not pleasant, but it's not the worst thing that can happen to a patient. The worst thing that can happen to a patient is that they not receive proper antiretroviral therapy, okay? And so I think we have some exceptions, some notable exceptions, especially infections of the central nervous system, most commonly tuberculosis and cryptococcal disease. Also, progressive multifocal leukoencephalopathy has been associated with. So anything that would cause increase in inflammation in the brain, obviously, when you have increased inflammation in the brain, the morbidity of that can be more rapid. And so we look at that and we say, so we want to be careful. But it's not true for all OIs. And I think it's important, in my view, it's not true for all OIs. And in my view is also shared by the WHO as shown here in the WHO recommendations. So, I think, and so this is just a schematic that's actually being looked at for the idea of some studies. So if we were to study this, can I say that what I'm saying, it's okay to start ART with the exception of CNS disease? Has that been well studied? Unfortunately, it has not. And so a lot of it becomes based on clinical experience. But this is a schematic that's being looked at for how we might study this to see if deferring ART versus same-day ART, when are you going to see the worst outcomes? And so the idea would be that, are there ways for us to establish what the risk factors are for potentially worse outcome with same-day ART compared to a potentially worse outcome with deferred ART? So this is just an example, without getting into details, of a way that we could be looking at this and studying this, because I do think that studies need to be done to be proven, but I think that the notion that any OI needs a delay in ART, I think it's not well founded in the evidence at this time. And I would love to hear comments on that, because I know that's not necessarily consistent with what a lot of people in this country believe, and I understand that. So again, in terms of management of IRIS, there has been some studies suggesting that corticosteroids can improve symptoms, but also because it can potentially increase immunosuppression. Again, it's a risk-benefit, a balance for the risk. But there is a trial on prophylactic prednisone, and it did reduce the risk of TB-associated IRIS at 12 weeks. So, take-home points from my talk: the prevalence of AHD among persons not on ART remains high in most settings, and as I said, is unlikely to decrease as countries achieve 95-95-95. Newer approaches to the prevention, diagnosis, and management of AHD need to be more widely adopted and adequately resourced. CLHIV have the highest mortality, so unique approaches are needed to the management of AHD, especially in children less than 5. Clients re-engaging in care are at higher risk for AHD, and DSD models need to take this into account. And finally, concerns about IRIS should not be used as a reason to delay initiation of antiretroviral therapy, in my opinion, with a few notable exceptions. And I want to thank a number of people that helped me with this presentation, and happy to answer questions either now or in the chat or I'll be here for the meeting for the week. Thank you.